Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Dania Reynolds. This episode features expert insights from a webinar titled Viral Hepatitis Update, CCO Independent Conference Coverage of EASL 2023, featuring Dr. Stefan Zeuzem, Professor and Chief of the Department of Medicine at the J.W. Goethe University Hospital in Frankfurt, Germany. For the full online educational program, including downloadable slides and video, please visit the link in the show notes for this episode. Now let's get started and hear what Professor Zeuzem has to say about new data on viral hepatitis from EASL 2023.
Just returned from Vienna from the international meeting of the European Association for the Study of the Liver, which lasted from Wednesday to Saturday last week. I think we picked quite a few very interesting abstracts and presentations, which I would like to show to you and discuss with you. And we should start first with the hepatitis B field. As you probably have seen in New England Journal of Medicine, this phase 2 study, which is unusual that phase 2 studies are published in New England Journal of Medicine, it shows that really important data have been generated. The BIPI study, which was just published, has now looked into some long-term follow-up, because there's a crucial question that if you have now patients where you achieve a functional cure, so patients who lose the S antigen, the question is, does this loss of S antigen remain, or do the patients re-seroconvert and become S antigen positive again? And therefore, it's of crucial importance that those patients who responded and achieved the final endpoint in the BIPI Clear trial, whether the response maintains. And this was looked in this study. And just to recall and to remind you that in the BIPI Clear study, the endpoint was defined as virtual undetectable HBs antigen, defined as less than 0.005 international units per ml, and HBV DNA levels below 20 international units per ml at the end of the BIPI therapy. If I recall correctly, in the New England Journal of Medicine, there were out of something like more than 450 patients, 26 patients who achieved this final endpoint, which was heavily celebrated because it's really the first major breakthrough. Almost all of those patients were now followed up, 25 patients, of which had 12 not received nucleotide analogues in the BIPI trial, and 13 had received nucleic acids. And we have now data from the follow-up period of 3 months in those patients who did not receive the nucleotide analog, and we already have 9 months of follow-up in those who were receiving the nucleotide analog. So looking into the data, it's very reassuring to see that the vast majority of patients definitely remain in the complete response. So looking here into those who had not received the nucleotide analog, 7 out of 9 patients maintained the response for at least more than 3 months. And follow-up is now in 3 patients already more than 9 months. And all of those patients are still in the mode of a functional cure. Those who received the nucleotide analog, together with BIPI, we have seen 6 out of 7 patients who remained in a full response. And those who have already a 9 months follow-up, 4 out of 4, so 100% have still S antigen loss and HBV DNA loss. So still an ongoing study, but reassuring that what is achieved with BIPI can be maintained over long term. And of course, this needs to be consolidated in larger studies and longer follow-ups. But again, very reassuring very exciting data. It's really one of the first breakthrough with new medications in hepatitis B to achieve S antigen loss and maintain this functional cure. Another company looking into strategies of eliminating S antigen is the company called Vir, and they have two compounds, or at least two compounds in development. They have the Vir 2218, which is an siRNA targeting the HBx region of the hepatitis B genome. And they have a monoclonal antibody, which is currently named Vir 3434. And this targets a conserved antigenic loop of the HBs antigen. They have looked with this combination into 3 cohorts of patients with various and variable durations of giving the siRNA and later adding the monoclonal antibody, or in cohort 2 to start both compounds at the same time, but continuing the antibody a little bit longer. And there is also a third cohort which uses a slightly higher dose of the monoclonal antibody at 75 milligrams instead of 18 milligrams in cohort 2. And here you see the responses. 90% of patients achieve an S antigen decline below 10 international units per ml by the end of the treatment. However, and this is disappointing, no participant who received the monoclonal antibody and the siRNA lost the S antigen, and the S antigen unfortunately also gradually rebounded after the end of treatment in all cohorts, which is shown in the figure below. So here you see the cohort with the late monoclonal antibody in green, where you have the steep decline only when the monoclonal antibody was given. And with the concomitant treatment of the siRNA and the monoclonal antibody, there was this steep decline, which was maintained at the end of the therapy. But you see in all 3 cohorts, there is this increase of S antigen after stopping the treatment. 6 patients were able to discontinue the nuke therapy, and 4 of the 6 remained off the nucleotide analog at the last available follow-up visit, but this is still small numbers. Then the company explored the same siRNA in combination with pegylated interferon. And as you recall, pegylated interferon is currently one of the approved drugs for the treatment of hepatitis B. And it was approved because pegylated interferon achieved S antigen loss in a subset of patients in the last decades. So it's no surprise that whatever you combine with pegylated interferon should achieve in some patients an S antigen loss. So the question is whether the pegylated interferon combination with the siRNA can perhaps increase the number of S antigen loss. And the standard dose of the siRNA was 200 milligrams subcutaneously every 4 weeks. And the pegylated interferon alpha 2A was given in the standard dose of 180 micrograms once a week. We have 5 cohorts, and they vary whether the siRNA is given alone, whether it's given and you give the pegylated interferon a little bit later, or you start both compounds at the same time, but you continue the pegylated interferon a little bit longer. And in cohort 4 and 5, there was the possibility to continue the treatment of the compounds and stop it in patients if the S antigen was below the lower limit of quantification and anti-HBs developed at a level of more than 10 milliunits per ml at 2 consecutive visits. Let's have a look at the data. You see that indeed only S antigen loss was achieved in patients who received the pegylated interferon, in particular those where the pegylated interferon was given somewhat longer, in a range of 20 to 30% of patients. There is a larger proportion of patients who achieved this when they started with lower S antigen, which is slightly a no-brainer. If you start with lower S antigen, you are more likely to lose it than if you start at a higher S antigen level at baseline. E antigen data were provided, and overall, the message of this study is that roughly 1 out of 4 patients, 24.8%, had a loss of the S antigen at the end of treatment, and 16.1 had a sustained S antigen loss also 24 weeks after the end of treatment. All participants who had an HBs antigen rebound after loss maintained with their S antigen level below 100 IUs per ml at week 24 of the end of treatment, but this is somewhat quite meaningless. We really want to achieve functional cure, which means loss of the S antigen, but at least a few patients achieved that. So it's good hope that the siRNA is augmenting the response of interferon. Here we have the S antibodies, which were generated in patients who lost the S antigen, and just like to go through that in those who had a sustained S antigen loss in the post-follow-up period, the patients also had higher anti-HBs titers, which is quite logical. Those patients who rebounded with the HBs antigen had lower anti-HBs. This is something we know for a long time, that a certain amount, typically above 100 milliunits per ml, that this development of anti-HBs is able to maintain the response. This is just verbally expressed here again. So 4 out of 4 patients with an anti-HBs more than 500 at the end of treatment had a sustained HBs antigen loss 24 weeks after the end of therapy, and 3 out of 3 patients with anti-HBs levels lower than 100 at the end of treatment had a rebound. So what you really need to achieve is an anti-HBs level certainly above 100. There were numerous studies and abstracts at EASL with novel agents on treating HBV. Many agents are still in the phase 1 development. And just to give you an idea what the novel compounds are like and their mechanisms, there are now ideas with gene editing with an Arcus polynuclease. There are still the capsid assembly modulators, and there are now some more competent and potent CAM modulators, capsid assembly modulators, which are also affecting the S antigen. The former CAMs, as you may recall, had no effect on the S antigen, and therefore there was a little loss of enthusiasm for the CAMs, but now the more potent CAMs are also affecting the S antigen. We are going to see more data probably at AASLD later this year. We have core protein inhibitors, we have GalNAc RNA interference compounds, and we still have immune modulating compounds like TLR agonists, TLR8 agonists. But here I must say, with the TLR agonists, we also have a large symmetry in hepatitis B treatment. Many of those compounds did not achieve what we were looking for, but hope is still ongoing with some new TLR agonists. With that, I'd like to summarize the take-home point for hepatitis B. Early evidence of durability of response with bepirovirsen, so an siRNA compound, short name BIPO, including population of patients receiving nucleotide analogues and those who have nucleotide analog cessation. But please be cautious. Small data size yet, and longer follow-up required. The VIR studies, the siRNA and the monoclonal antibodies, provided additive antiviral activity, but no S antigen loss, only if you combine the siRNA with the pegylated interferon, you had some S antigen, which is summarized in the last bullet point in roughly 25% of patients. And there are further studies planned with the siRNA and pegylated interferon, and perhaps even the addition of the monoclonal antibody. We are then moving to delta hepatitis, and I'd just like to have some very early comments on delta hepatitis. At the EASL meeting, a new clinical practice guideline was published by the EASL Association, and I'd just like to remind everybody that the treatment which is advocated in this practice guideline called the bulevirtide has only a provisional approval yet in the European Union. It's not yet approved in the United States and not yet available in the United States outside clinical trials. So please look in the clinical practice guideline. It's certainly a little bit the future for my colleagues in the United States, but it's already real world in European centers which have access to bulevirtide. We have seen in the MIRROR 301 study now longer treatment with bulevirtide, monotherapy in patients with chronic hepatitis delta. Previously, the data were shown for the primary endpoint of the study at week 48. And here, the primary endpoint, which was a combined endpoint of HDV RNA undetectable or decline of HDV RNA of more than 2 logs plus ALT normalization, was achieved in 45% of patients with the 2 milligram bulevirtide treatment and in 48% in those patients who received bulevirtide 10 milligrams subcutaneously on a daily basis. Looking now after 2 years of therapy, you see that there is an increase in the primary endpoint from 45% to 55% with the 2 milligram dose and from 48% to 56% with a 10 milligram. So if you look the two doses at week 96, it's almost identical results. So the decision of the European Medical Agency to give provisional approval for the 2 milligram dose seems to be the correct decision. If you now see the viral decay data, you have the 3 arms. One arm had a delay of treatment start of a year. And you see that if you delay the treatment and you start 1 year later, you will see a sharp decline of the HDV RNA, which comes to very similar results at week 96 to those patients who were already on the treatment for 48 weeks. If you look just on the viral response, the data are even more promising. At week 48, you have, with the respective doses of 2 and 10 milligrams, 74 and 76% virologic response after 1 year of therapy and 76 and 82% after 2 years of therapy. The ALT response is a little bit lower, and this, of course, has the impact on the combined endpoint. The undetectable HDV RNA is shown on the far right panel, but here I'd just like to mention to everybody that the extraction methods are going to matter quite a bit, and there is quite a substantial difference whether the HDV RNA measurements is performed after an automated extraction of the HDV RNA or a manual extraction. And therefore, I don't like to comment too much on those data because we always need to know whether the RNA was extracted automatically or by manual extraction techniques. Very important that the longer treatment over 2 years had no further safety issues. So we clearly see higher response rates after 2 years of therapy, but no changes in the adverse events or serious adverse events leading to discontinuation. And the safety is a very constant feature of bulevirtide over 1 or 2 years. Here we have the efficacy endpoint, just quickly summarized. Important to note that the S antigen loss is not observed with this treatment, but clearly the most important issue is the decline of the HBV DNA, and bulevirtide has very little effect on baseline HBV DNA. So it's clearly a very promising drug for the Delta and a less promising drug for hepatitis B, and therefore the future development of bulevirtide is mainly focusing on Delta hepatitis. We had another large study presented at EASL, and this is the largest hepatitis Delta study ever performed in the world. And this is a study looking into the effect of lonafarnib, an farnesyl transferase inhibitor, in combination with pegylated interferon. Since the half-life of lonafarnib is quite short, it needs to be boosted with ritonavir to have a twice daily dosing. Otherwise, the drug would need to be given 4, 5, 6 times. So without ritonavir, it's implausible to give lonafarnib. Ritonavir boostering for pharmacokinetic reasons is necessary. We had 4 arms, patients receiving only lonafarnib with ritonavir, with lonafarnib, ritonavir plus pegylated interferon, a pegylated interferon monotherapy control group, and a placebo control. So wonderful design, a large study, and all is that the overall results for lonafarnib are somewhat disappointing. So at the end of therapy, which was the primary endpoint shown here in the blue bars, we had with lonafarnib alone 16% who had achieved a more than 2-log decline of HDV RNA. And please compare to the previous study with bulevirtide. If you combine with pegylated interferon, it's 36%, but even with interferon alpha alone, you achieved 44%. And therefore, the incremental benefit of adding lonafarnib to pegylated interferon is certainly not statistically significant. ALT normalization is shown on the right side. The positive message here in this study is that 24 weeks after the end of therapy, this is shown here in the red columns, the responses are maintained. But the question is whether in Delta this is going to be maintained over 1 year, 2 years, 3 years. We know from prior studies with pegylated interferon that many patients are relapsing even 1, 2, or 3 years after the end of therapy. Interestingly, because a large number of patients had 2 biopsies, the arm where patients received lonafarnib, ritonavir, and pegylated interferon showed a statistically significant endpoint of the histologic composited endpoint, which was no worsening in fibrosis and an at least 2-point improvement in the HBsAg score. But the disappointing thing is that it was only seen in the combination arm and not seen in the other arms of the trial. Important to understand for everybody is that lonafarnib has initially, for the first 24 weeks, quite a nice effect on HDV RNA decay. But after 24 weeks, you see quite a substantial rebound occurring. This is something you observe typically in drugs where the virus develops a resistance profile. But since we are not targeting the virus, but structure of the host, the mechanism why we observe a rebound is completely unclear. But the increase in HDV RNA can be accompanied by quite significant ALT flares, and therefore there is a considerable amount of surveillance necessary if you would need and if you would treat patients with lonafarnib. You have to be aware of these breakthroughs, these rebounds, and the combining ALT flares. We'll see how the development of this compound is pursuing. And we had a third study in Delta, which was an siRNA from Janssen called GNJ3989. And we have here a design where patients received an immediate active treatment, or there was a placebo running phase for a year and a deferred active treatment. And I'd just like to show the results briefly. If you look at the left panel, there is a very nice decline of the S antigen with this compound. In the delayed treatment arm, of course, there was no effect because it was a placebo treatment. Also in the middle panel, there are nice results that the HDV RNA is declining, only, of course, in the active treatment arm, constant HDV RNA levels in the placebo arm. But unfortunately, the treatment was accompanied by substantial numbers of ALT flares. And this is shown here in the next slide. More than 3/4 of all patients, 76.5% in the active treatment, had significant AST elevations, which in fact led to the discontinuation of the program. And this compound is not going to make its way in the clinic due to safety reasons. And there were, of course, some additional analysis on the outcome by ALT elevations. They were typically associated with on-treatment HDV RNA rebounds. The mechanism is completely unclear. It's more frequent in patients with high levels of HBsAg at baseline and high HDV RNA at baseline. But nevertheless, 3/4 of the patients achieving or suffering from high ALT flares led to a decision not to continue this drug development. So my key points here on Delta hepatitis are that the MERS 301 study showed that bulevirtide given over 2 years of treatment was definitely associated with an improved combined outcome compared to a 1-year treatment, and continued without additional safety issues and remained well tolerated. No patients virtually discontinued treatment for safety reasons, despite the fact that this drug needs to be subcutaneously injected on a daily basis. Patients receiving lonafarnib in combination with ritonavir achieved a composite primary endpoint with improvement in the histologic outcome, but only in combination with pegylated interferon. So we need to see how this compound is going to be developed. There are attempts to go into further treatments with lonafarnib in combination with other interferons, in particular lambda interferons, and we need to see those data in the near future. The J&J compound showed a reduction of HBsAg and HDV RNA levels, but due to the ALT elevations, the study is, despite being planned initially, the program has been discontinued, and we are probably just going to see completion of the ongoing study, but no new pivotal trials leading potential approval of this compound. I would like to finally switch to hepatitis C, and I'd like to introduce a study from Ireland, which was a community HCV treatment study on patients with opioid substitution. It is run in the largest hospital-based ID HCV clinic in Ireland. Target patient groups are sometimes, of course, missing their appointments, particularly because they have no housing. They looked into the alternative linkage to treatment pathway in collaboration with the substitution services, with nurses and general practitioners. And the idea was that one-stop shopping is going to be organized with opioid substitution, HCV assessment, education, baseline lab, fibroscan, drug-drug interaction checks, and treatment registration. The antiviral compounds are dispensed at the same time from the same community pharmacy as the treatments for the opioid dependence. And the current study evaluated the outcomes from this initiative. Just a look on the characteristics of the patients. There have been overall 283 patients in this clinic. Of those, more than 80% underwent the HCV screening. There were 31% positive by antigen test or the PCR, and there was a very reasonable and good linkage compared to other ideas to DAA therapy, and we had the majority patients, majority HIV negative, non-cirrhotics, and here you see in the lower right corner the used antiviral regimen. And there was an ITT SVR rate achieved in this very difficult to treat group of 65%, which is a little bit lower than what we have seen in other groups. It really depends on how chaotic these patients are using drugs, how the substitution is working. But the good news is on two hands that there's a very small proportion of patients who did not complete the therapy. So I trust that with the ongoing study, the SVR rate may still improve, and that the number of patients who show reinfection is in the range of not more than 10%, but still highlighting that education and means of avoiding reinfection are of additional crucial importance, in addition to provide direct antiviral agents. And then there was another study looking into the effectiveness of a nurse-led HCV test and treat program in female prisons in the United Kingdom. Interesting to hear that the HCV prevalence is higher in females than in male prisoners in the UK, which is probably not the same in all countries in the world. I would suspect that in my country it's the other way around, but interesting data. And there are at various states test and treat programs in this population, and the study here used regional nurses which optimized the test and treat pathway for new prison admissions, and whole prison HCV intensive test and treat events were implemented in February 2020 and March 2020, and an anonymized HCV database dashboard was created and updated monthly. And the data are shown here. The blue line shows that the number of new admissions tested was steadily increasing and getting quite close, over 90%, which is a real good rate. And the RNA prevalence over time seems to somewhat decline, which is good news and is somewhat indicating that higher rates of treatment and prevention strategies seem to work, and that, of course, those patients who tested positive, started therapy and cured, led also to a substantial decline in the HCV RNA prevalence in the investigated hospitals. Another interesting study, this comes back to that Mr. Google knows probably everything, looked into machine learning strategies to improve HCV screening and linkage to care. So what was done here was a data set of almost 300,000 patients, of which 50,000 were HCV positive. And the data of those patients were used to develop a machine learning algorithm to improve screening to diagnosis ratio. The algorithm were assessing clinical variables and social determinants on health. There was a stepwise feature addition to improve precision and minimize pop-up alert fatigue. And there was a model performance assessed in a healthcare system with a test data set of another 26,000 patients, of which were almost 5,000 HCV RNA positive. And what was found with this machine learning were numerous factors associated with HCV diagnosis. So here it was age, male sex, of course, increased ALT and AST levels, but interesting also higher creatinine levels, glucose, hemoglobin, bilirubin, white blood cell counts, and platelet counts, probably reflecting fibrosis and advanced stage diseases, came out as factors associated with this diagnosis. The numerous medications, of course, came out associated, in particular, of course, substitutions and opioid partial agonists, and other diagnoses were also associated, which I found quite interesting. I'd just like to read them out. Infectious parasitic disease, nicotine dependence, of course, opioid-related disorders, presence of transplanted organs, liver diseases, chronic obstructive pulmonary disease, psychoactive substance-related disorders, vaccination, interestingly, and inoculations. Social determinants of health, lower income, longer distance to healthcare facilities, methods of transportation, prevalence of smokers in the patient's geography, limited access to healthy food, higher prevalence of housing for communal living in patients' geography, higher unemployment, and lower frequency of patients' visits. And it's interesting that with these data, the validation data achieved a 91% positive predictive value with a 30% sensitivity and an ROC of 96%, which I think is quite impressive and gives me again the impression that with this kind of data, the possibility to improve the precision of testing is very substantial, and I think this should be further elaborated and probably needs to be validated, of course, in different cultural and geographical regions in the world, but could really improve the diagnosis rates and probably also the linkage to care. Getting the key points here for the hepatitis C, I like to summarize that an opioid substitution treatment clinic, collaborative service with nurses and general practitioners can improve linkage to HCV care and clinical success. I think this has been shown in numerous studies, and the study from Dublin is just another adding to this insight. In female prisons in the UK, nurse-led test and treat program increased HCV screening and decreased the HCV RNA prevalence, suggesting that HCV microelimination is achievable. I like to put a little bit of water into the wine because that was run in female prisons, and it seems to be, from my information from doctors treating patients in prisons, much more difficult in male prisons, but this needs to be further explored. Female prisons seem to be easier motivation of the incarcerated people to go for treatment and testing and treatment. Interesting for me, very much the FIND-C study, where machine learning improved potential HCV screening to diagnosis ratio using combination of clinical and social determinants. I think this has to be validated in different healthcare systems, different cultural regions, different continents, but I think it's a very interesting approach and should be pursued, trying to achieve the WHO aim of final elimination of hepatitis C on a global level. With that, I'd like to thank you, and I'm happy to go with Daniel into the question and answer session right now. Thank you.
Thank you so much, Professor Zeuzem, for the excellent presentation. I know we're a few minutes over, but I was hoping we could still maybe get to one or two of our audience questions. One of the first one coming from Marie, I think this is may have been asked during some of the bulevirtide studies that you reviewed, and maybe more for you with the experience with actually accessing bulevirtide in Europe with the conditional approval, whereas we don't have access to it quite yet in the U.S. But how accessible is the medication, and have you had success in actually acquiring it logistically for patients?
Well, in Europe is, of course, state-specific. It's extremely easy, accessible in Italy and in France. It's quite easy accessible in Germany. Many other countries still have higher restrictions. But of course, the conditional approval is for the whole European Union. The issue is around reimbursement, and this is, of course, very much state dependent. From our real world experience, we can only confirm the data of the MERS study, and we have used this compound also quite extensively in patients with compensated cirrhosis or decompensated cirrhosis, which is outside the label. But when we are desperate, we sometimes use it in this off-label situation as well. And so for limited data, which have also been presented at EASL, show that even in these very advanced patients, bulevirtide is still very well tolerated. The question is, of course, whether this treatment can still avoid liver transplantation in these patients. Here we need longer follow-up, but from a safety perspective, it's good news.
Wonderful, thank you. And also related to bulevirtide, with the MYR 301 study with the 2 and 10 milligram doses, do you think that there is any point in continuing trials with the 10 milligram dose at this point?
Good question. The drug is only available up to 5 milligrams. So with 10 milligrams, the patient would need to inject himself twice, but perhaps this could be in a different preparation, be optimized. Currently, I think every hint is towards the 2 milligrams, but there may be occasional patients, whether they are a little bit heavier or have other clinical conditions. Some few patients may have a slightly better antiviral response with a higher dose, but I still believe that the 2 milligram will be the one which goes forward in the regulatory and approval process. The question will be whether in, let's say, moderate responders, there may be a chance from the regulatory authorities to attempt to increase the dose, but this is currently not solved. is a completely open question. And I think we should initially really stick to the 2 milligram because that's really seems to fit for more than 90% of patients.
Wonderful. And then just one last question from Fu. He thanked you for the bright update with viral hepatitis and says, historically, chronic hepatitis B only controlled HBV in the plasma and circulation. Do you feel optimistic about progress in regards to control of eradication of HBV inside the liver hosts?
That's a good question. I'm not convinced that a functional cure, which is meaning that S antigen is lost and anti-HBs is induced, that this means that there is definitely no virus any longer in the liver. And I take this from data of patients we consider always cured. These are patients who are S antigen negative and only anti-HBc positive. We have had transplantation of those patients who were just anti-HBc positive, and yet the patients who received the organ developed hepatitis B. So there seems to be some CCC DNA which can survive, and therefore I am not terribly optimistic that the functional cure really means sterilizing cure, that no replicating HBV virus would remain in the liver. It may happen perhaps occasionally, but I'm skeptic that this is going to be a general aim we are going to achieve.
Thank you very much to our faculty, and thank you to our listeners for joining in. To learn more about our coverage of EASL 2023, including slides and video, see the link in the show notes. Please be sure to check back for more episodes on important infectious disease topics. Thank you and have a great day.